Welcome to Best of Day ACG2016. This is the third part in our series, and I'm Miguel Reguero, Professor of Medicine at the University of Pittsburgh Medical Center. And today I'm joined by Dr. Susie Kane, Professor of Medicine at the Mayo Clinic in Rochester, Minnesota. So Susie, some interesting abstracts today, and tell me in part 3, what did you find most interesting? What stood out to you?
Sure. So the first study that I thought was particularly clinically relevant was the Olmsted County experience with PCP pneumonia and the incidence. As we both know that when you immunosuppress patients, that's a deadly complication and something that we would certainly want to prevent and prophylax against if we thought that indeed our patients were at risk. So with combination therapy, with monotherapy, if it's steroids, if it's triple therapy, what really is the risk? We hear from the rheumatologists, we hear from the pulmonologists and the ID specialists, and obviously they all have their own take on this.
Right.
So the question was, well, really, as a gastroenterologist, what's the experience, right? So the Rochester Epidemiology Project that follows the population-based IBD patients based in Olmsted County, Minnesota, were tracked over a decade long, and that the person years of exposure to either monotherapy, dual therapy, or even triple therapy could be examined. And it's interesting that there were only 3 incident cases of PCP over that time frame, and that 2 of the 3 cases actually had an underlying pulmonary disease to begin with. All of the patients were over 65 years of age, and that ultimately the calculated risk cumulatively was less than 1% per 100 patient years of exposure. Now, the patients who are on triple immunosuppression, so steroids, a biologic, and an immunomodulator, were clearly the interest group that we were concerned about the most. But fortunately, there was the fewest amount of data for that group, which suggests that we don't keep our patients on triple immunosuppression for a long enough time. So I thought that that was a good negative finding in our study.
So getting rid of the steroids and just using the combination.
Exactly. So the question that came up during the discussion was, how about things like cyclosporin, which we know as an exposure in and of itself is an increased risk, and that there weren't enough patients with cyclosporin exposure to see any kind of risk. But certainly that would be another study to do in perhaps a clinical alliance type of situation or something like that. But the bottom line is that we really don't see in our IBD population, if you're combination therapy treated, that PCP pneumonia certainly does not look like it needs to be on our radar.
Good. So it sounds, so it's very interesting, because for a long time we would use antibiotics as prophylaxis, as you allude to, with thiopurines, with combination biologics, and with steroids. So even in the highest risk groups, we're finding that this is extremely rare. And I think, as you said, and just to reemphasize, the take-home really is, it's rare. Right. The second take-home is we probably don't need to prophylax all of our patients and put them through antibiotics, which could have into itself some adverse consequences.
Correct.
So I think that's really good. And so let's maybe move to the next one. In this part 3 series, what did you find the next interesting one?
So there was a study looking at the agent tegligatide, which is an agent that is used for short bowel. And so the question is, well, we have patients with Crohn's who have functional short bowel or surgical short bowel. And the question is, from the data from trials where patients were given this agent versus placebo, was there a difference in the patients who had IBD as their underlying etiology? Because there are certain risks, obviously, to promoting growth of villi and small bowel intestinal tissue. And so is there a concern for that? Are you potentiating flares of these patients or somehow enhancing the immune response that they are flaring? So I thought that it's a small niche, but that potentially clinically relevant for those few patients who you may actually be considering giving this, because these are patients who are on long-term TPN, even maybe lifetime TPN. They have stomas, and that perhaps if you can help them enhance the absorptive capacity, that you may be able to get them off TPN,
Right.
just like in the non-IBD short bowel patients. So this was a retrospective study looking back at that data from the experience
cohort.
of that cohort it was the STEPS trial. And they actually showed that the IBD patients did better. And that it was numerical, not statistically significant,
Right.
but that it made me feel better that at least there wasn't a negative trend, and that certainly it didn't meet statistical significance, that I shouldn't be considering this as an agent for some of those few handful of patients who really could help, who it could potentially help.
Right. So I think the take home that I hear from what you're saying is, we might have an agent in our IBD patients with short gut. Some of them, as you know, we consider short bowel as far as small bowel transplant. Maybe there's something we can use. And I think one of the interesting things I heard as well was that we were able to decrease parenteral intake and parenteral nutrition in these patients. So like you said, maybe we can get these patients off TPN or down on TPN without harming them in terms of Crohn's flares or colitis flares. So this is interesting, and I think that they didn't talk about cost, which obviously is going to be an issue, but I think going forward, this is an exciting agent.
It is, and the fact that this study wasn't long-term,
Right.
so obviously there's going to be that consideration. But when we talk about cost, TPN is very costly.
Sure.
So this is a costly therapy, but if it saves the TPN cost as well as the potential complications of long-term TPN, then it's a win-win for our patients.
I agree. So good. So I know that there was one more abstract we were talking a little bit ago that really kind of intrigued you, and it's near and dear to your heart as far as the studies you've done. So talk to me about that. Tell us what that looked like.
So this was a breast milk study, and so this wasn't maternal serum levels or infant serum. This was breast milk. And that there's been a lot of work, obviously, around serum levels and exposure in utero, but let's say you get the mom through pregnancy and now she wants to nurse.
Right.
What are the data?
Common question.
Common question. And certolizumab, we know, doesn't cross the placenta, but okay, you've crossed that hurdle, but what if you're exposing your infant to it in the breast milk and you didn't realize it? And the fact that this is not just a typical IgG immunoglobulin like the other anti-TNFs, because it's a fragment and the PEGAL component too, that the pharmacokinetics may be completely different. So it is important that it gets studied separate from infliximab and adalimumab. So it's very important to do this study. And what I congratulate the company and the investigators for doing was taking the time to actually develop an assay that is milk specific, not trying to extrapolate and use the serum assay and say, well, can we get close with, because milk is not serum, obviously. And the other important thing to remember too is that they used mature milk. So these were mothers who were at least 6 days postpartum, and so this is not colostrum or immature milk. This was mature milk, and that these were serial collections over time. And so I think it's important as clinicians, and not necessarily gastroenterologists, but concerned clinicians, that we understand two new concepts. The RID, which is the relative infant dose. And what does that mean? So you care about how much of an entity is in milk. And so there is a standard across the lactation literature that for any entity to be less than 10%. That's the magic cutoff. Well, it turns out that certolizumab is at 0.125%.
So really low.
So really low. And the other concept is ADID, which is average daily infant dose. So how much is an infant seeing, and is it that on any given day that there may be enough circulating that would be of concern?
So it's kind of the cumulative over a longer period of time.
And again, so the ADID for the study was actually 0.003
Wow.
milligrams per kilogram per day. That's really, really low.
So it sounds like the safety is great. So as you go through this, and I think in a minute you'll get to the big take-homes, so interesting, methodologically, very good study, new assay, looking at milk, and then they really spent the time to do this well to look at the mature milk. But it's interesting, these new concepts as far as exposure to the infant.
Right.
And from what you're saying, it doesn't just look like it's just below the cutoff, it looks like it's really low.
Correct.
And not only the average daily dose,
Correct.
but the exposure to the infant.
Right.
So I guess go on, but tell me when you contextualize this and think about your practice and the practices of others out
Right.
there, what does this mean to you?
Well, so I think that it's obvious that it gives me a lot of comfort to be able to counsel women that they can feel comfortable about nursing and that there is not going to be any exposure to their nursing infant. I mean, the theoretical absorption of the gastric mucosa of these sort of entities has always been the concern by neonatologists, and it just does not seem to be on that radar for this.
Safe.
That also it's important to just note that we're 18, the sample size was 18.
Right.
So we are talking double digits here. It wasn't 5 or 7,
Right.
which is the number of moms that we've tested for other entities in breast milk, because it's very difficult to do this study.
Yeah.
You think about how many women are pregnant in a couple of years in the practice, and then how many who want to nurse and can nurse and then want to actually be part of a study and donate milk samples as frequently as they did. So this was a really difficult study to do.
So like you said, I mean, complimenting the authors and the company, extremely well done. And I think if I were to use the take-home points from what you had just said, it's safe, certolizumab in pregnancy, which wasn't part of the study, but certolizumab in breastfeeding.
Right.
And the exposure to the infant in the breast milk is negligible.
Right.
And it's such a low dose. I think the take-home message is
And
you're
it's-
saying is you don't have to stop certolizumab when you breastfeed.
Right. And certainly if you need to start a biologic
Right.
in the postpartum period. So say that a
Good
woman
point. Yep.
was with stable disease, she flares after delivery.
Right.
And now you're considering starting a biologic,
And
or there had
maybe-
been a discussion about a biologic and she had declined during the pregnancy, but now she's in the postpartum period, that I would feel very comfortable initiating certolizumab as her treatment while she's still nursing, because
So that's another interesting and important component. It's safe to start in
because
postpartum in breast milk. It seems to be okay as well. So with that, maybe we'll conclude, and I really appreciate the time. I mean, this is a fascinating study, and I have a feeling, given your interest, you can look at all the angles, but methodologically looks good. Safety's very good. I think the take-home is certolizumab's okay to use in breastfeeding mothers. They don't need to stop, and they could potentially even start as well. So I wanted to thank Dr. Susie Kane for her time and presenting those 3 interesting studies as part of Best of Day ACG 2016. This was part 3. Again, stay tuned. We have one more part 4. And thank you for your attention, and thank you for joining us.